Thank you so much, Ms. Kranick, for those kind words, those kind remarks. We are so excited to have with us today Dr. Dexte Cherney. Dr. Cherney is a population health innovator responding to chronic disease and health disparities with workplace wellness incentives, food as medicine strategies, and Blue Zone insights. Board certified in preventative medicine, public health, and lifestyle medicine, he earned his medical degree at Howard University College of Medicine and his master's in public health at the Medical College of Wisconsin after attending Loma Linda University. He previously served as the president of the American College of Lifestyle Medicine, where his membership in the board of directors spanned many years. In 2021, he joined Advantis Health as Senior Vice President and Chief Medical Officer of Community Wellbeing and the Blue Zones Institute, where he is described as leading the work of the Blue Zone Institute as a living lab to create and codify best practices that can be replicated across regions, as well as capitalizing on and enhancing the strength of the Blue Zones portfolio to serve communities of greatest need. In his former role as Chief Medical Officer and Senior Vice President of Clinical Affairs at FoodSmart by Zip Pongo, Dr. Cherney executed a national food as medicine strategy, employing telenutrition solutions to address poor nutrition and food insecurity. Dr. Cherney promotes a 360-degree approach to lifestyle changes to manage chronic disease and is co-author of the book, Integrating Wellness in Your Disease Management Programs. He previously served as the chair of the Tennessee Diabetes Prevention and Health Improvement Board and as chair of the Business Strategies Committee for the Centers for Disease Control and Prevention National Diabetes Education Program. For 12 years, he served as the American College of Medical Quality's elected delegate to the American Medical Association. He has demonstrated a rare talent for bringing key stakeholders together to drive population health innovation in multiple settings and environments, and is a visionary regarding how the United States healthcare landscape may be beneficially redesigned throughout the future. Here we have Dr. Dexte Cherney.
Hi, everyone. Thank you so much for that introduction. It's such a pleasure to be here. And I am going to share my screen. I understand there may be a little bit of a delay. But again, it's just really my pleasure to be here. And it's so exciting. You know, this is optimal aging. And as I go through my presentation, I hope you can sort of see how the dots come together in terms of Blue Zones, what they are and how that works and applies to aging, and also lifestyle medicine. And the sweet spot here is really how these two sort of work together in combination. It's really pretty exciting. The other thing I'll add is that this is being held out of Louisville, and you'll see some slides here from Cummins Engine, where I worked as the executive in charge of their healthcare benefit, as well as oversaw their clinics as their chief medical director. So, you know, some of this that I'm talking about is actually right in your backyard. So that's pretty exciting as well. As I go through this presentation, I want you to think about how is health produced, because that's what we're really trying to strive for, is how is health produced. And so as I go through that, you'll see me come back to this time and time again. As was said in the introduction, one of my roles is the president of the Blue Zones Wellbeing Institute. And while the name says Blue Zones, that's just because we understand how important community is to how health is produced. But we also understand how important lifestyle medicine is. And so what the Institute does is to say, how do we combine these things? And then how do we put people, places, and then how do we drive the policy forward to enable lasting change for these communities as well as individuals? We want to do this in a very practical approach. We're not doing science just for science. We're doing it to figure out really how do we apply this in the lives of individuals. again, asking the question, how is health produced? The World Health Association and others have told us now for many years, this is nothing new, that it's really boils down to lifestyle. It's how we move, it's what we eat or don't eat, and that's really where health is produced. I mean, there are some things in terms of genetics, there are some things in terms of healthcare. This particular pie chart is actually skewed a little bit because, as you'll see later in this presentation, environment and lifestyle are closely linked, as we know and as we see when we look at social determinants of health. We also know that by and large, as Americans, we don't live a healthy lifestyle. This is one of the reasons that we see chronic diseases at the levels that we see, and oftentimes increasing. So about 3% of Americans live a healthy lifestyle, and you can sort of see the 4 dimensions that they looked at here. This was from the Mayo Clinic a few years back. What I will also tell you is that if you were to look at the Harvard nursing study from the early 2000s, you would see about the same percentage. And so what that says is that even though we are now 2 decades beyond the Harvard nursing study, we still have not made much progress in terms of living a healthy lifestyle. And that particular survey was done of nurses, medical professionals, and even those were not living up to the standards. It was actually 3.5%, so about 0.5% better, but again, 2 decades ago. So what do we need to do to change? We know that by and large, we're losing the battle in terms of lifestyle and our health. We know that, for example, the majority of us, at least adults, are actually either overweight or obese. So that's not the norm. I mean, that is the norm. And we see that about 1/3 of our children are, and then of course, unfortunately, about 54% of our pets are too, our dogs. And I put that up there because I want to stress the point that what would we recommend for our dogs to lose weight? Would we recommend bariatric surgery for our dogs? Because that's often what now is being recommended for our children, is that, the usual things that we do, diet and exercise, aren't enough, that somehow we need these very sophisticated, complicated solutions to the problem. But what I'm here to say, and what you'll see, is that we really should go back to some of these basics. But there are other ways that we can go about it that perhaps can be more effective for us as we go forward. One of the things that I like to point out is that we have genes that are coded when we're born. And but we also know that our environment and lifestyle is part of our environment can actually affect the expression of those genes. So what I'm showing here in this particular slide is the DNA for identical twins. And what you can see, they're identical twins, but they're separated early in life. And what happens is the expression of their DNA changes based on the exposures that occur in their lives. And they've done these studies several times now, and what they find, and when they look at these twins that are separated and they go to different parts of the world or different parts of a country to live in, maybe with different families, they find that the rates of cancer, the rates of obesity, the rates of diabetes are different. And so what's different? They have the same genetic makeup. What's different is the lifestyle and the exposures and what that exposure has on genetic expression. The term for this is epigenetics. And this is very powerful. I use an example of a patient that comes to you and says that, everyone in their family has lung cancer, and you find out that everyone in the family smokes 5 packs of cigarettes a day. You might think, well, that's pretty obvious. Don't smoke those cigarettes. Well, that's an example of how that smoking, your lifestyle actually affects the genetic expression, because if those people did not smoke, the genes that they might have that would turn on for lung cancer would not be triggered. Now, some of us might have genes that even if we smoke, we think of George Burns and people like that that smoked well into their 90s. They didn't get lung cancer, but not all of us have those genes. The good thing here is that even if we do have those genes, oftentimes if we don't expose it to, poor lifestyle habits, those genes are not turned on. And that's very encouraging, and it can be motivating too, because imagine if you don't know this information and you have a family history of certain things. You may say, well, my fate is my genes. I can't do anything about it. I was born with those genes. But what I'm saying is that oftentimes we can change the expression of those genes based on our lifestyle habits, and that's very important. As I mentioned, starting out, blue zones, for those that don't know, these are communities in the world where people live well into their hundreds and they're not sick. They are healthy, they are striving, they are active, they're climbing mountains with their sheep, their shepherds and things like that. And there are 5 of those zones in the world. And you might say, well, if they're shepherds and they're doing all of these kinds of things, then they're probably living in some idyllic place. And some of these places are, like Costa Rica and Greece. But there's also a blue zones that's in North America, and it actually is in Southern California, about 60 miles from Los Angeles. And it has all the typical things that you would expect of a Southern California city. It has the smog, it has the congestion, it has all of the stressors of life. And yet, this is a community that is living well into their hundreds, and they have all the attributes of these other communities, blue zones around the world. And so what they have found is that community, like the other blue zones, share some things in common. They share what we call the Power 9, and it's how they move, it's how they connect, it's how they eat, and the right amount of exercise, and they really don't exercise. And the thing is that these people are in these blue zones are not signing up to go to the gym. They're not waking up saying, how can I be happy today? They're not saying, how can I be healthy today? It just happens. And so they're living this lifestyle. It's the easy thing for them because it's just part of their community. And everyone in those communities is really doing very well from a health perspective. I say that because I'm going to talk about, and I'm going to pivot into lifestyle medicine, but you should also understand that probably the reason that we need lifestyle medicine is because most of us don't live in a blue zones. Those people in Icaria and Sardinia, they don't really need lifestyle medicine because their environments with how they eat, how they moved, and those things are conducive to living a long, healthful life full of happiness and being very vibrant up into a very old age. And so, but we don't all live like that. But the good news is we can start to structure our environment, and we can start to do things that will put us on that path. And how we do lifestyle medicine can also be beneficial for us as well. So I've said some things about lifestyle medicine. So what is lifestyle medicine? Well, if you think about the things that I just mentioned in terms of what we find, those 9 elements in blue zones, a lot of those are the same in terms of lifestyle medicine. So lifestyle medicine is physical activity, it's nutrition, it's sleep, it's stress management, how we use different substances or don't use certain substances, and healthy relationships. And we do those things, the reason for the arrows is that we do those things in a balanced approach and with a therapeutic dose. And so let me say a little bit more about a therapeutic dose. If I had a backache and my doctor said, well, you should take some NSAIDs, aspirin or something for your backache, and he only gave me 1 milligram of aspirin, I probably wouldn't get much benefit from that, because we know I should probably get 650 milligrams to really feel the effect. The question would be, because I didn't get an effect, is it that the aspirin isn't a good remedy, or is it because I didn't get a therapeutic dose? The answer is we didn't get a therapeutic dose. And a lot of the things that we do around these activities that you see in lifestyle medicine is that we're not getting a therapeutic dose. So it has to be done in the right way, and it actually takes some expertise to do this. But when you do that, you get some remarkable results by doing that. This is just a slide that sort of compares lifestyle medicine to the blue zones. So again, there's not probably some surprises here, but lifestyle medicine is actually using a clinical approach to move some of these individuals into that blue zone of longevity. It's a very powerful way to think about your patients. I often talk about if you're growing a plant in your garden, what does that plant need to be healthy? Well, we basically know that the plant needs to have the right soil, the right nutrients in the soil. The plant needs to have the right amount of sunlight and the right amount of water. And you need the right balance, just like lifestyle medicine. You need the right balance. You need a therapeutic dose. You need just enough water, not too much, not too little. You need just as much sunlight, not too much, not too little. But you need all of those things in order to have a healthy plant. If you only give it water and never give it sunlight, it's not going to do very well. Well, the human organism is the same way. We need the right amount of food, the right kinds of food. We need the right amount of physical activity. And when you do that, just like the plant, everything gets better together. So for the plant, the roots get better, the stems get better, the leaves get better, and it produces good fruit or vegetables, whatever you're growing. The human organism gets better too if you give it the right nutrition, the right activities, you stay away from tobacco. Everything about that human organism gets better. The immune system, we see that with COVID, gets better. Type 2 diabetes gets better. Obesity gets better. And I'll say a little bit more about why that is. It's very complicated in some ways, but it's also very simple why that happens. And so that's what this is doing. And that's why it becomes so powerful, because when you start making lifestyle your foundation, all of these elements of what we consider to be healthy actually start to flow from that. This is a graphic that I lifted from proceedings that occurred in Pittsburgh a couple of years ago at UPMC. And they did a 2.5-day summit on lifestyle medicine, and they brought in all the experts in all the different domains of lifestyle medicine. And this is one of the things that they showed in their proceedings. Dr. Mike Parkinson led this with funding out of the Ardmore Institute of Health. I had an opportunity to attend some of this as well, and it was very powerful. And these are the things that are really driving lifestyle medicine. We've heard a lot about the microbiome and how your diet and your stress and medications can affect your microbiome and why that is so important. We've already mentioned in the previous slide about epigenetic changes, what can happen there, and cellular stress and injury in terms of free radicals and antioxidants that people need to have, and where the lifestyle medicine interventions work. And a lot of this leads into chronic inflammation. And we know that chronic inflammation is really at the heart or the root of cancer and some of these things that result in chronic diseases. And so that kind of gives you an idea of where this is effective and why it works so well and why it does that. I would also add here that lifestyle medicine has been actually a part of normal medicine practice or typical medical practice for some time. If you look at chronic guidelines for how you treat individuals, this is from the American College of Cardiology, you see that they mention lifestyle as a foundation. But the other thing you'll notice here is that the rest of the document or the guidelines is only gives like one little line, and not even a full page on lifestyle, but yet they say it's the foundation. Everything else is about, well, what's the drug that you need to prescribe for these individuals? So what lifestyle medicine does is it just spends a little more time on what everyone understands as the foundation of good health. I would also just want to sort of differentiate where lifestyle medicine fits. There is a board of lifestyle medicine, and you can become board certified in lifestyle medicine. There are also boards in preventive medicine. I happen to have both lifestyle medicine and preventive medicine. And while lifestyle medicine is also preventative, lifestyle medicine actually treats diseases that you already have, not just preventing disease, but actually treating those diseases. And it differs a little bit from functional medicine and integrative medicine. All of these things are related in some ways, but I wanted to, this is a nice slide if anyone has any questions. Well, what's the difference between lifestyle medicine versus functional medicine versus integrative medicine? Integrative is more of the complementary things such as acupuncture and things like that, chiropractic, and how you integrate that into a practice. And in a later slide, I'll show you how at Cummins we actually did all of these things. But the foundation was lifestyle medicine. We certainly practice preventive medicine and early detection and screening as well, and even some functional medicine in terms of some supplements, but not too much of that because we're really trying to move the lifestyle piece first. And these other things kind of come on top of it. And I'll show you a slide of that in a minute. But we know that this kind of approach to care can be very effective. Again, going back about 2 decades ago, you can see from the initial diabetes prevention program how effective lifestyle was versus metformin in this particular example. And yet, even today, when a patient comes in with prediabetes, most often the clinician will reach for the metformin and not so much really have that conversation that needs to be had with lifestyle. The other thing I want to point out in terms of difference between preventive medicine and lifestyle medicine is that most of the things that we deem as preventive medicine do not address the root cause. They do not prevent the disease. So for example, a prostate-specific antigen, the PSA test, does not prevent prostate cancer. A pap smear doesn't prevent cervical cancer. A mammogram doesn't prevent breast cancer. What they do is important. They detect disease early on so that you have to be less aggressive in treating it. It's easier to treat and you get better survival that way, but it doesn't really prevent. Now, the exceptions obviously are things like immunizations and vaccines, but lifestyle medicine can actually prevent things because, again, we were looking at the epigenetics around some of these things as well. So there's good science around that, and that's the distinction. This particular pyramid shows where lifestyle medicine should fit. It's the foundation, and then the physiology is more like the functional medicine with the supplements and things like that, the vitamins and minerals. And then, of course, prescription drugs and surgery. So that's kind of the hierarchy of how one would practice lifestyle medicine. I did a lot of my early work at Vanderbilt University, where I was a professor, but I was also in charge of the health benefits for our 25,000 employees. And we did a lifestyle program, and we showed an ROI within 6 months. And part of that was because we were able to move people off of medications. And some of these medications were very expensive. We compared to assess that ROI. We compared individuals that had type 2 diabetes year over year, quarter over quarter, and you can see some of those percentage changes here. And we compared them to type 2 diabetics that were not in the program. And you can see what those are. And we also compared their trends, cost trends, to everyone else in the plan as well. And you can see the remarkable differences in cost. And again, even within that 6 months, what was happening is that people were coming off of their medications, and that was leading to the savings, particularly when people were able to come off of specialty drugs. And most of those specialty drugs that they were on, at least those in this program, had to deal with inflammation. So if you recall the chart that I showed that came out of the summit at UPMC, inflammation was the key cause, right? And so if you're really decreasing inflammation, then you're able to come off of some of these very expensive medications. You know, some of them are like $40,000 a year. And so you just move a few percentages there, in terms of people coming off of those medications, and you can see your ROI pretty quickly. The other thing is that a lot of people believe that they know how to live a healthy lifestyle. And here's an example that came out of, I believe this came out of Truven. And it talks about how people say, oh, I know how to eat healthy. I just need to do it. And yet, or they even say they are, but yet when you really look at what's happening and what they're eating, they're not really living up to that. I give you an example. People will often say, well, I just need to cut out the carbohydrates. You know, I'm eating too many carbs. And the issue really isn't the carbs, because if you look at this is from USDA, what you'll see is that we were actually at the turn of the century, turn of the last century actually, eating a lot more carbs in our diet than we were, say, in 2005. And yet we didn't have issues of obesity. And now we're eating fewer carbs. And yet we still have this issue, and people are still saying, well, the carbs are what's bad. Really what it is, it's the refined carbs. You know, if you think about the calories that you get in eating a cylinder of potato chips, it's about 900 to 1,000 calories. You'd have to eat about 6 potatoes to get the same number of calories. And no one's going to sit down at one time and eat 6 potatoes. They'll fill up maybe after 2 potatoes. So that's an example of a non-refined versus the processed or refined carbohydrate. And the carbohydrates that are refined are the ones that are getting us in trouble, but it's not the carbohydrates itself. And I'll say a little bit later about potassium in the diet, and potatoes are actually an excellent source of potassium. And it's a very important thing that we need to control blood pressure and things like that. So again, just an opportunity to understand what's really driving this and where we need to go. Another example I'll give is that people say, well, I'm cutting down on my carbs, and I'm eating, cottage cheese and a lot of healthy stuff. And again, I would caution us that cottage cheese perhaps is not as healthy as we think. Actually, none of these cheeses are that healthy. It's very high in saturated fat and very high in sodium. And I just point out cottage cheese, a half a cup is actually, more than a half of the sodium that you really need for the entire day. And people are eating this way, and they'll say, well, but I still have high blood pressure, things aren't moving for me, but they don't realize where a lot of the sodium and things like that are coming in their diet. So another example, the portfolio diet, that was a study that they did a few years ago, shows you the power of diet compared to a drug for cholesterol, lovastatin. And you can see the control versus the diet group versus the lovastatin group at 4 weeks were actually pretty similar. And of course, the diet fulfills a lot more things than the statin does. And I'm not saying that you never take a statin, but the thought is, what can we do with just changing diet? And this was a pretty simple diet. And we've had some other examples of that. We know the Geisinger story, where 80% drop in costs over an 18-month period, drop in A1C, better improvement in terms of cholesterol, triglycerides, just based on prescribing people fresh food out of their food pharmacy with an F versus a P. Earlier on, I mentioned potassium that we get in potatoes. We also can get it in bananas. But the reason potassium is important for our blood pressure is that we think of sodium as driving our blood pressure, and it does, but potassium in our diet actually counteracts the effect of the sodium. So it's important to have that potassium as well. And about 90% of us don't get enough potassium in our diets. Things like hibiscus tea have been shown to be very effective. And hibiscus tea, if you go to the grocery store, you look for the thing that says Zinger, and the tea that has Zinger has hibiscus if you look at the first ingredients on the label, and it can be very effective in lowering your blood pressure. And this is a good example of food as medicine, but it's also a nice substitute in lieu of sodas. So if you are have a patient who doesn't want to start drinking water in lieu of their soda, or some might call it pop, then hibiscus is a nice thing that they can transition to. Other examples of why food is so important, we have sulforaphane here that's found in broccoli, and it's been linked to inhibiting breast cancer, stem cells. We know that sugar, for example, is not good for us. I think our mothers probably, I think someone, okay, I think I'm live now. And so we know that sugar can actually affect our immune system. And about 100 grams results in our white blood cells being about 40% less effective. That's something to keep in mind during this COVID time. Someone might say, well, what's 100 grams of sugar? Well, that's about what you get in one milkshake. So stay away from those milkshakes during this time. I have a lot of examples. I'm keeping an eye on the clock here, so that's why I'm going a little bit quick here. But I want to make the point in terms of how powerful some of this can be. Trans fats, associated with type 2 diabetes. Oftentimes people think that diabetes is just because of, again, too many carbs, too much sugar, but actually it's the fats in our diets that can actually wreak havoc here. The other thing I always like to talk about are blueberries. And this is just one of the benefits of blueberries. Blueberries have so many benefits, but they did a study and they looked at women that had cervical cancer, and they were, this particular stage of cancer was appropriate for radiation therapy. And if you use radiation therapy alone, you can see the slide here. You had a cancer cell reduction of about 20%. When they added blueberry extract to this, they saw about a 70% reduction. And so what I like to say here is that we can't say that lifestyle medicine will get rid of all your cancers. That's a promise that no one can make. But what we can say is because it enhances the immune system so much that why not give that a try? You can add it to therapies like this, or you can use it in a preventative way and just eat more blueberries to begin with, eat more broccoli to begin with, get the trans fats and other fats out of our diet to begin with, but certainly use it in combination as well. And what's the harm? There really is no harm. There's no adverse drug effects from some of these things, and it can be very powerful. I mean, that 20 to a 70% reduction in cell count, I mean, that's huge. So those are some of the things that we need to keep in mind. The other thing I'll say is that for the most part, you just can't take a supplement and get the same effect. The balance of nutrition that you find in whole foods is much better and much more bioavailable to your body than a single element that's been extracted and then reinserted. And we've seen where this can actually be harmful. So they did studies back in the 1990s where they were just giving people vitamin A because they saw that people with lung cancer had lower levels of vitamin A. And in fact, it was detrimental to those individuals because it wasn't in the same package that nature gives it to us, where there are about 250 cofactors that go along with that vitamin A that are so important in how our body uses it versus just the supplement by itself. So, we need it. Food it's important, obviously, and it's only one component of lifestyle medicine, but it's a very important component. As I said, I did some of this work at Cummins, and it's a manufacturing organization, and Six Sigma is part of what we do. And Six Sigma is all about what's the root cause of the problem or the failures that we have. And if you take that approach to healthcare, it really boils down back to lifestyle. We're missing some of those direct elements. And again, we've seen this in blue zones and we've seen this elsewhere. So how do you change people's behavior to get them to want to do this? I like to use the phrase well-being change equals MC square. And that's intrinsic motivation, competencies, and culture. The culture we talked about a little bit with Blue Zones. But the competencies also has to do with, should I eat, refined carbs or unrefined carbs? Are those the same? And what's happening with my doctor in my doctor's office? Is he really also doing the kinds of things that will help me? And what's my motivation and where does it come from? This is an article that was in Fortune magazine back when we were doing some of this. And we were really looking to reverse about 10% of our type 2 diabetics of our 55,000 employees, and using lifestyle medicine to do that. If you look at the literature, the only two things that can actually reverse type 2 diabetes are lifestyle medicine and bariatric surgery. Bariatric surgery has a remission rate of about 30%. Lifestyle medicine ranges anywhere from 80% to 20%, depending on when you catch the type 2 diabetic. And I just remind us that there are about 45 medications for type 2 diabetes, but none of them actually results in a cure. So if we're going to do this kind of thing, you really have to have physicians that understand the appropriate therapeutic dose, how to make the combinations to really get a lifestyle medicine to really get the impact. Unfortunately, most of us as physicians, I'm no different, really don't get a lot of education in this. In fact, get about less than 3 hours. This was a JAMA article that came out a while back, but get about 3 hours of nutrition. And it's really on the deficits. It's like scurvy and beriberi and things like that, not on the things that we're talking about now. So the American College of Lifestyle Medicine, the American Board of Lifestyle Medicine now has programs that physicians can go through and actually become board certified. And that's important. Going back to motivation, one of the motivators is that no one really likes to take medication. And so at Cummins, we had this in our lobby that said, would you like to stop taking your medications? And we're a lifestyle medicine practice here. And so it could be an opportunity, it could be possible. That's motivating for people. And so instead of spending your money on copays and deductibles for medications, particularly for specialty drugs, why don't you redirect that to wholesome, healthy food and avoid that? This is a picture of our teaching kitchen there, and it was oversubscribed. There's a waiting list to get in there and learn this, because what people found out is that healthy food could actually taste good if you showed them how to do that. And some of the examples of competencies: how do you control your blood pressure through diet? How do you control your cholesterol? How do you decrease your risk for cancer? How do you control your brain health? Again, this is optimal aging. How do you decrease the risk for dementia and things like that? And so that is something that was very important. We really changed the definition of patient-centered. There are 8,760 hours in the year. How much of that time is actually spent in front of your provider? How is health produced? Most of the time, how health is produced is based on our environment and our lifestyle, which does not occur in the doctor's office. And so we designed, what kind of tools, services, benefits, changing environment to the extent possible to really drive and empower the patients to actually take better care of themselves. Patient-centered, patient empowerment is really what we were striving for. Again, the docs need to know how to prescribe this in the appropriate dose. This slide is just an example of how a lifestyle medicine doctor would approach type 2 diabetes and weight management. And you see the traditional approach is basically physical activity and diet. But what about the microbiome? What about chronic stress, sleep, medications that affect the microbiome? The chronic stress and cortisone also has to do with, when you eat. because when you eat, you increase the cortisone. And so if you eat too late at night, you're doing those kinds of things as well, and it may affect your sleep too. So these are the kinds of things that a lifestyle medicine practitioner might do. This is the prescription for an anti-inflammatory diet. So cruciferous vegetables, green leafy vegetables, dark berries. And if you don't like blueberries, well, what about strawberries? What about raspberries, cherries, those kinds of things? If you don't like spinach, well, try the kale, arugula, those things too. So it gives people some choice among all of these good things. This particular slide just shows the results that we were able to achieve within 7 weeks on cholesterol. And so what you'll notice there, 44% of the people entering the program had a high total cholesterol, about 50 some odd percent had a high LDL. And within 7 weeks, on average, we could reduce that by 16%. Some people reduced it by as much as 50%, over 50%. And 98% of our folks improved on the program. And this was a mixed group. These were people from different age brackets, different ethnic groups, and still we were able to achieve that kind of change. 20% average reduction in the bad cholesterol, again, in 7 weeks. And what this did is it really emboldened our chief financial officer to say, you know, some of these cholesterol drugs were, you know, $15,000 a year. And the conversation was, well, how many people are you going to get to do that? Well, I only need to do 100 to get, you know, 1.5 million in savings with some of these very expensive cholesterol drugs. These are not the statins, but there's a whole nother class of drugs that were coming on the market at the time that ran about $15,000 a year. And so, again, we still have people that smoke. So you're not going to get everybody to do this, but if you can reduce it, you know, percentage-wise, you can really move forward pretty nicely. This is just a picture of the clinic there down the road from you in Columbus, Indiana, down the road from Louisville. And it was an integrative practice. So we did have acupuncture, massage, and chiro. And we just built this into what we were doing. You can see a picture of the physical therapy facilities as well as the teaching kitchen. And it was a teaching kitchen as well as a demo kitchen. So we would do demonstrations, we would videotape those so that if you weren't right there in Columbus to participate, you could go online and see the videos, sometimes even of the CEO cooking his favorite healthy food. So it sort of brought the people together as a community. Again, it was oversubscribed. There was a waiting list for many of the classes. We tried to have a very inviting atmosphere because lifestyle medicine and the things we were doing, we want to get people there even before they have a condition. People that were just interested in, you know, being more healthy would come there as well and learn from these experts in the field. Again, this was our chief chef, Sandy Thomas, with a husband and wife. So again, couples could come in. Actually, people brought in their children as well because it's important to get children to eat healthy at an early age. This was a book that was in every exam room. Some of you may know Dr. Michael Greger. What he does basically is every year he reviews about 3,000 of the top articles on health and nutrition, and then he does videos, he writes books, he writes blogs about it. The interesting thing about this particular book is that the back third of the book is nothing but the citations. And so we had a lot of scientists and engineers that work at Cummins, and they always wanted to see the data. What's the data? What's the science behind this? And so Dr. Greger's done a great job of doing this. And so we had it in the clinic, and if a patient had, say, type 2 diabetes, there's a chapter on that, and they could read about it. If they had issues of leukemia or lymphoma, they could read about how food and diet might affect that based on the articles, and the citations were right there. So They could actually look up the articles themselves and read about it themselves. And many of them did, not everyone, but many of them did. And so it was just a nice thing to have there. I'm going to end with this because I know we're a little short on time, is that in the area of nutrition now, what is happening is that we understand how important nutrition is, but it's up till now, it's been very difficult to do a nutritional assessment. There's food frequency questionnaires and things like that. And it takes time. It takes often a registered dietitian to perform. Dr. David Katz, some of you may know him, has partnered with Dr. Walter Willett out of Harvard, Christopher Gardner out of Stanford, Michael Dixoner out of Tufts, et cetera. And they've come up with something that can actually do a dietary assessment within a few minutes. And it's easy, it's simple. They can do it actually before they come into the clinic. And it's almost like the eye exam. Is this how you eat, or is this not how you eat? And it actually dives down into it, does this dietary assessment. And the goal here is that dietary assessment will now become a vital sign. And so this is going to be, tools like this will now enable clinics and practitioners to even do a deeper dive with their patients easier in terms of lifestyle medicine, because they'll use it just like they use blood pressure and how fast the blood pressure is as well. One of the nice things about this is that no matter where you are on the nutrition scale, and no matter what kind of food you like to eat, because we know that food is so personal that it needs to be, sensitive to culture, ethnicity, et cetera, et cetera. And not everyone wants to be a vegetarian. And so there's a progression here that's available to those patients too. And so they've done a really good job. I have no financial interest in Diet ID, but I just think it's something that's very novel and very right for the times to really get to some of this food as medicine that we need to get to. And so with that, I believe I'm right at time, the time that I was allotted. I apologize for having to go so fast, but I'm happy to take any questions.
Dr. Shirley, could you, oh, good, yeah, there you go. All right, thank you so much. That was wonderful. We have several comments in the chat. Let's see, we're opening it up now on our end to see if we could throw a few questions your way. Are you at the top? So, sorry, we're still going to the top. All right, so Joe has a question for Dr. Shirley. What obstacles do you see in trying to infuse lifestyle medicine into modern medicine?
Well, the issue with that is reimbursement. So a lot of the work that I do now is around reimbursement through the Institute. And if you think about it, healthcare is a business. Healthcare is a business, and very few people that are in that business, and when I say people, I mean institutions or entities, are able to generate revenue off of healthy people. A hospital doesn't make money off of empty beds, just like a hotel. Pharmaceutical companies don't make money if their drugs don't sell, and physicians are usually paid fee for service, RVUs. And if they're not operating, if they're not doing those things, then there's no money. And so everyone sort of gives lip service to, I want to keep you healthy, but they really want to fix you when you're broken because that's how they make money.
Right.
And so we really have to sort of figure out how we can align everyone's incentives. So as payers, we want to lower the cost, but as providers, we actually want more. I've worn both of those hats in my career, and I can tell you when I'm on the payer side, the employer side, like Cummins, it's like, I want to reduce my cost for my employees and I want them healthy showing up to work. When I'm on the provider side, oh, that was a good year because we had 20% more of those particular procedures. And so the incentives are not in line, and that's really what is really standing in the way. But I am hopeful, I am optimistic that we can start to align those incentives. And we're actually launching some randomized control trials with reimbursement attached to test some of these ideas.
Oh, we'd love to hear those results as those come forward. All right. So let's see. This is cute. How do you deal with reluctance from providers who think that lifestyle medicine is voodoo? I have a feeling that might be Joe's.
Well, you know what I always say is that they haven't tried it. It's true. I mean, and they have to have a therapeutic dose. Again, they're probably looking at giving somebody that 1 milligram of aspirin and then saying aspirin's no good versus a comprehensive therapeutic dose. And if they try it and they do it the right way, they will see that it actually is very effective.
Right. Thank you. And then we have one, who manages the patient when the team implements lifestyle medicine?
Oh, that's a great question. Well, it is a team, and usually the physician is sort of the captain of that team. But I will tell you that the coaches, the dietitians, they all need to play a role in that and to be supportive of what's happening. In fact, at the Cummins Clinic, the people that answered the phone had some background in lifestyle medicine because we wanted everybody to be aligned and in sync. For what we were trying to do there. So everyone plays a role. It just depends on where the patient is and what they need at the moment.
So much great information, but it seems also very overwhelming. What's the one thing you can tell people to do today to improve their health?
Oh, wow. It is overwhelming. I guess if I had to say one thing is I would put a novel concept out there about know your numbers. And the numbers I'm talking about is the amount of fiber you get on a daily basis in your diet. And I want you to shoot for anywhere from 40 to 50 grams of fiber on a daily basis. The lower number is more for women and the higher number is a little more for men. And do that and you will see some remarkable changes in your life. So count fiber. You know, you'll have to search a little bit to figure that out, but what you will find is that you have to gravitate to a diet that's higher in antioxidants, a diet that's lower in cholesterol, a diet that includes more vegetables and fruit, because that's where the fiber is. And you'll also find that you fill out a lot faster too, but you're eating fewer calories. So that's the good thing. But that would be one of my challenges to the group if they want some place to start.
Yes. Yes, lentils help me that way.
Lentils
Right?
are so high in fiber, right? And they're high in protein. People don't realize that, you know, that's where you get a lot of protein on a plant-based diet. Yeah.
Those black belugas help me out.
One of our magic superfoods that we all should be eating every day.
That's right.
Well, I mentioned a couple of those. I mentioned the blueberries, kale,
right.
broccoli. I mean, you know, Dr. Joel Furman talks about G-bombs. You know, you need to get G-bombs in your diet, and G-bombs stands for, I'll probably miss one here, but greens, beans, onions, mushrooms, and berries, you know, and seeds, you know, so nuts and seeds. And so, you know, eat the colors and get some G-bombs every day, and you'll be well on your way. And count your fiber. All those things, by the way, have fiber.
That's right. I think we have enough time for one more question. Is that right? Oh, we do? Oh, oopsie. Let's see. What was it? It was, let's see, we're getting back to it. Just a second. Let's see. Any thoughts about changing healthcare systems from treating sickness that occurred over time to risk reduction to prevent disease?
Yeah, you have to change the reimbursement system. So if you think about, everyone talks about value-based care. And so if we really move, but if you look at the literature, I was just at a conference last week in Orlando where I spoke, and one of the guys was talking about risk-based care, and only 4% have downside risk. Only 4% of contracts in value-based care, and we're a decade beyond when people first started talking about this, and we're only at 4%. So it's still a fee-for-service world. And until you really change that, this isn't gonna happen. And so that's why, you know, we're trying to do more about, you know, really aligning incentives. And one of the things we're doing is we pay docs for actually the reversal of disease, not even in the first year, but every year after that, because there's still savings accrued to the system. So now the doctor doesn't have to worry about, well, now I've cured this patient, I'm not going to see them as often, so therefore my revenue goes down. No, we're going to pay you in the out years as well. So that's some of the things that we're experimenting and I know we don't have time today, but it's a deep, rich conversation, and those are the kinds of things that are going to move the needle.
Will you come back next year and share that with us?
I'm happy to do that.
Oh, great. That's wonderful. All right. Thank you so much, Dr. Sherney. It was a pleasure. We learned so much. It was a great way to end the conference. We
Well,
really
thank
appreciate it.
Thank you for having me. It's a pleasure.
Thank you. And I hope all of us get our therapeutic dose of the 6 pillars of lifestyle medicine. We'll have to remember that. All right. Thank you. All righty.
Thank you.
All right. So now it's time to, sorry, I'm getting there. All righty. So we have come to the conclusion of our conference. I hope everyone has enjoyed the conference and took advantage of every learning opportunity made possible and available to you over the last few days. We want to thank our sponsors once more for supporting us this year as we host the conference again virtually. Next year, we're going to be face-to-face. Woo! We're going to be able to send a big thank you. We want to send a big thank you to our Optimal Aging Conference Planning Committee. I think we have a few individuals that might be bringing something here for our few members. I don't know if I hear footsteps as of yet, but I think they're on their way. We'll continue on. And then we'll hear our footsteps. All right, so we asked that Barbara could come to the front and maybe Justin and Kelly. We want to thank you so much for all that this is from all of us to you. Thank you so much for all that you've done to make this. And where's Kelly? I think Kelly might be behind the scenes. All right. We've had such a wonderful conference, and we thank you so much for all that you've done for creating the vision and implementing all of this, all of the behind the scenes, the registration and recruitment, the sponsors. Love you. We thank you. Thank you so much. Thank you. Thank you. And I hope you enjoy. Oh, thank you.
A shout out to our amazing team, though. There's so many different people behind the scenes making this thing happen. Each and every day of the conference. We started Saturday, we're finishing today. So thank you to the entire team, everyone who helped.
Yes. Yay! All righty, and we just have a few housekeeping things here. So as we conclude, please don't forget to complete the evaluation. You have been provided a personal link that you've been using throughout the conference to complete your evaluation for each session and for the conference on a whole. So please check your email one more time for this link and complete this evaluation. If you're requesting CEUs, the evaluation for each session must be completed. This is the last session of the conference. Complete the evaluation in order to earn those CEUs. If you have not found the time to go to the exhibit hall, it remains open for a few more days. Take a look. Also look for follow-up emails from our conference planners with important information about how to access conference materials. Last, mark your calendars and save the day for the Optimal Aging Conference that will be face-to-face next year. The dates are April 15th to the 18th, 2023. More information to come. Until then, we see you next time. Thank you so much. Yay!